Okay, hello. So we're going to be talking about biological effects of ionizing radiation, dose measurement and risk estimation. Okay, so you are aware of this, so it's a bit of a recap, but it's always good to keep in mind. Obviously, X-rays are famous for being able to go through tissue, but if they were to go through tissue entirely, then there would be no use. So they have to be absorbed partially in some tissues and less in some other tissues so that we get an image. But of course, X-rays being absorbed means that they cause some biological damage. So the effects that X-rays have, or ionizing radiation has on tissues, are called either somatic effects, which occur in the individual exposed, or genetic effects, which occur in the descendants of the individual exposed. We're going to be, virtually entirely interested in somatic effects. Okay, it's known that very high doses of radiation, so when we talk about high doses, we're talking about 5 gray, which is 5,000 milligray, given to the whole body can mean that the person dies. So if you've watched something like Chernobyl, then you'll know that, or I think there's a couple of submarine movies that I've watched where somebody's had to go into the nuclear reactor to fix a pipe or something, otherwise the whole crew will die. And they've obviously had a very high dose of radiation to the whole body. If instead of it being, something that was throughout the body, and it was just a beam, for example, a very high dose beam restricted to a limited area of the body, then you probably get some very bad local effects like burning of the skin, etc. But it might not be fatal, but it could be. And then cumulative dose over a number of weeks or months, that may be, fine because no one exposure was high enough, and the cell's body can repair itself. So that's the way that we believe radiation works. We've got data from very high radiation doses and from accidents, but we haven't really got much data from low-level radiation doses. Okay, so those somatic risks, they're either deterministic, which means they have a threshold dose, or they're stochastic, which means that they are potentially, even a tiny dose could start the whole process off of detriment. So deterministic effects, the more radiation you give, then the severity of the effect increases. Whereas stochastic effects, you could have a very light radiation dose and get the full-blown disease, or you could have lots of radiation and not actually ever get the disease. Okay, so leukemias and solid tumours, cancers, are stochastic effects. These are the things we're mostly concerned with in diagnostic radiography, obviously. There are a couple of occasions where deterministic effects happen, but virtually never. Here's a graph to show what we've just said. So basically, if I use my mouse pointer, you can see that once the threshold is reached in terms of dose, so this is dose, and this is the probability of something happening, then the reason why it's called deterministic, because as soon as you hit the threshold, then it will happen. Yeah. Now in the population, there'll be people who are more resistant to radiation and other people who are less resistant to it. So it may, you've still got a little bit of a probability curve here, but between this threshold where at least one person will get the issue, to this threshold where everybody is going to get the issue, then that is a deterministic effect. You can predict it. Here we've got a similar graph with dose and severity, and as you can see, the average person, the average individual, as the dose increases, then the severity increases in a deterministic event. Somebody who's particularly susceptible to it will get more severity from a lower dose, and somebody who's quite resistant to it will get less severity from a particular dose. And on a severity graph, there'll be a level of clinical significance before you have to sort of start treating the person. So it'll go past that once you get to this dose for everybody. Okay, a stochastic event, as the dose increases, then the probability of the event happening increases, but you can still get the event here at a very low dose, and you can get the event at a very high dose. The severity doesn't change. You know, if you get cancer, unfortunately, from a radiation, then you'll get it at the same severity, whether you have a small amount of radiation or a large amount of radiation. Okay. There is a lot of debate around what happens when you get a small amount of radiation. All our current thinking and all optimization literature and all legislation goes through a threshold non-linear, a linear no threshold graph, a linear no threshold graph. So basically what's happening here is there's some data around patients who've had a lot of radiation. These were basically atom bomb survivors or people who've had radiation doses due to the erroneous sort of use of linear accelerators, or you know, there was a time when people would be given radiation dose to try and cure diseases. In the 50s and 60s, they got given high amounts of radiation to try and cure certain diseases, and they were tracked, and we knew what they died of eventually. So we've got some data sets, and those data sets don't go below about 0.05 sieverts. So everything below that, which happens to be in the diagnostic energy range, so in this bit here, what tends to happen is that we best guess that by extrapolating our line down. So basically there's a theory that a little bit of radiation will give you a little bit of risk. A little bit more will give you a little bit more. A little bit more will give you a little bit more, until we get into the range where we actually have some data. So here we have the data points. These block points here are the epidemiological data points, where we've looked at the populations that have had some exposure and then tracked them and found out what they died from. And we can figure out that they did indeed, the people who got most radiation did indeed die from cancer more often than the people who got less radiation. So there are data points, but as you can see, none of those data points are down here in the area we operate in as radiographers. And there are various theories. So some people have a hypersensitivity theory, which is this orange dot, which indicates that actually people are more radiosensitive at low doses than we think. And then there's the linear no threshold, which is the one we apply. And then there's a threshold belief, whereby you can give a certain amount of radiation and nothing will happen. And once you hit a threshold, then it will start to occur. And then there is even a hormesis theory, which is that low amounts of radiation actually do you good and are protective against certain cancers. And so the idea here is that if you irradiate cells a little bit, then they will repair themselves, and that repairing will also repair out some of the genetic problems that might have led to cancer. So actually forcing the cells to repair can actually be a good thing. Putting a bit of stress on your body can actually be a good thing, and radiation's no different to any other stressor. So that's the hormesis view, and there's quite a few serious scientists who sort of follow a hormesis view, in which case, as a radiographer, you'll be actually doing the population good by x-raying them, not just by coming up with a diagnosis, but by giving them a small amount of radiation. But we don't have any data. These are all theories. The only data points on this graph are up here. Okay, so what do we have to do? We have to believe in the threshold, the linear no threshold model, because that's what's enshrined in legislation. Okay. So this is basically just saying what I've just said there. Now then, more recent sort of research, also published in Radiography as it happens, looks at some various cellular responses to radiation, and it identifies a few effects, one called bystander effect, one called hypersensitivity, and one called adaptive response. So bystander effect, basically it seems that cells communicate with one another. So a damaged cell will communicate to the unirradiated cells within the irradiated volume. So you can actually have an effect on tissues that aren't irradiated. And that's called bystander effect. The hypersensitivity is where there apparently seems to be a group of patients who are actually hypersensitive to radiation. And we don't know who they are, but it's similar to people who have a particular gene for breast cancer. They're very susceptible to getting breast cancer. So this would be a similar gene which makes people very sensitive to radiation, but we haven't found that gene yet, so we don't know who they are. And they would, if we were to find them at some point, we could label it in their notes, and they could be avoiding X-rays, even more than we normally do. So something that would be justified for one group of people wouldn't be justified for them because they'd be highly sensitive to it. That may well come in the next 5 or 10 years. And then adaptive response. So this is part of this hormesis idea, the idea that when you irradiate a cell, then it can have an adaptive response, and then it hardens it for future irradiation. So it's possible that you end up with a protective effect for a future dose. All this is all theory. Nobody has any real good data on it yet. Okay, by exposure, what do we mean? We mean sort of putting someone in the beam of X-rays. We're going to come on to a sort of technical term for exposure in a minute, but that's what we mean at the moment. So, both the absorption processes in diagnostic radiography that absorb energy from our X-ray beam, that's photoelectric effect and the Compton scatter effect, both result in liberating electrons, and those electrons then gradually deposit the energy that they're being given in the biological material because they have interactions with other electrons. There's a sort of chain of events that follows the exposure to ionizing radiation before biological damage occurs. So in diagnostic radiography, where radiation doses are very small, deterministic effects should not occur. However, they have been noted in angiography exams. So if you do cardiac angio, then you maybe can see skin reddening on a patient a few hours afterwards on the ward if they've had a long exposure time, and if the X-ray beam hasn't moved much. So we can actually get involved in something called skin sparing if you do angiography, where you would actually stop the beam from irradiating the patient in one particular location, and you would move the actual gantry round to another projection and start screening from there. So if a cardiologist or a neurologist was or a radiologist was concentrating really intently on trying to get a guide wire or something through a vessel, and they were they were fixed on looking at the image and they were screening quite a lot, then what you could do is ask them if we could just change projection. So you just change the point of view a little bit, and then they can continue on concentrating. And what you've done there is you've evened out the irradiation from one part of the skin to another part of the skin, so that you get 50% of the radiation in two different areas rather than 100% of the radiation in one area. So that's an optimization technique that has been shown to work, and you'll find research papers on that. So that might be a paper that you could include in an annotated bibliography. It's called skin sparing. Okay, but that's the only time we really see deterministic effects in diagnostic radiography. There's never been any evidence of genetic effects from diagnostic exposures, so it's somatic effects that we're really concerned about. The thing about genetic effects in the human population is they're actually quite high. In natural life, there's about 1% of live births have some sort of genetic defect. So what's happening is radiation may give a very small increase, but it's ridiculously low. The risk is way lower than 1%. So it gets masked by all the other things that might be happening, which might be causing genetic effects. So there's no data to show any genetic effect from radiation. Right, so let's just go through the chain of events. So we have an exposure. That leads to ionization, which means electrons are freed up by Compton or photoelectric interactions. The ions, the negatively charged and positively charged ions, become free radicals, and those free radicals then interact chemically with other elements and molecules and compounds in the cell, and make something happen. So molecular changes can happen, and if this happens in compounds that are important to cell division, such as DNA or RNA or enzymes, then you can get cell damage. So you can break membranes down and the cell dies, or you can change things in chromosomes or nuclei. So that then, at a cellular level, either means the cell dies, which is a deterministic effect, or you get cell transformation. And that cell transformation might be repaired, or a stochastic effect might occur. The cell might have a particular thing switched off, which may lead it to become cancerous. Okay, so here we have some graphs of some of the data that we do have. So the Hiroshima and Nagasaki atomic bomb survivors, they had measured excess deaths. So as you can see, the black line here is the expected death rate due to, in this case at the top, solid tumours. So this is cancers that are solid cellular tumours. So there was an expected death rate, and it increased with age. So, below 40 there weren't very many deaths due to cancer. About 60 there's a few starting to show up, and at 80 there's a few more. And what happened was, those Hiroshima bomb survivors that had detailed about half a sievert of radiation, which is way more than our X-rays would give, showed this dotted line. So they were showing more deaths by cancer. Not a huge number more, but more. Those that had 1 sievert of radiation, they were showing more again, deaths from solid tumours. Okay, now when you look at blood-borne cancers, leukemias, then they were impacting the younger generation, and lower dose estimate here, 0.2 sieverts or 200 millisieverts, they showed a blip in the ages of 30-year-olds getting cancer, getting leukemia, which wasn't expected at all. And 0.4 sieverts gave even more of a blip of people getting leukemia that shouldn't really be getting leukemia. This is the normal trend in young people. Okay, having said that, look at the axes of the graph. This is this is actually a very small effect here. It's been magnified up. This is not the same scale at all. So this would actually be very, very low blip if we used this scale. Okay, so that's the data that we have. So let's get on about measuring it. So we've done the why measure it. You know, why should we be bothered? The reason we measure radiation dose is because of all those biological effects that we don't really want, and we want to quantify it. Now, how do we measure it? So this is the how bit. So basically, there's a unit called the gray, and that's a measurement of energy deposited. Okay. And there's another unit called the sievert, which is a measure of risk. So these two units are different. The gray is a measured unit. The sievert is an estimated unit. And there has to be some calculation to get from a gray to a sievert. You can't measure a sievert on its own. You have to measure a gray, measure the energy deposited, and then you have to work out where it's been deposited, what type of energy it was, and then you can calculate the sievert, which is what we're going to do in a minute. So where I've got a blue thing, this relates to measurements of energy. Yeah, so all the measures of energy are radiographic practice or research. So all the measures you'll see reported are all measures of energy, apart from there's one very special case which I'll mention in a minute. The sievert, as I've said, can be calculated from these measures, but we need extra information, like you need the age of the patient, you need the gender of the patient, you need to know where the radiation happened. You need to know quite a lot more information than just the radiation energy absorbed. Okay, so here are some of the places from which we can measure radiation energy absorbed, which is dose. So the top here, when the radiation comes out of the light beam diaphragm, we measure that there, and that's called the dose area product. And that's a multiplication of the intensity and energy per unit mass at the point multiplied by the size of the collimated area. So that's dose area product. The next one that we come to commonly and see is entrance surface dose. And entrance surface dose is a measure of the amount of energy absorbed per unit mass at the crosshairs, at the centering point, at the skin surface where the radiation enters the patient. Okay. Next, you can measure the organ dose, but you can't do that with a real person, right? So when you're x-raying a human, you can't measure the organ doses. You've only got these two doses really you can measure. Whereas if you were to take a plastic phantom apart and put little thermoluminescent dose meters where the organs should be, then you can measure organ doses by taking them out and putting them in the annealing oven and working out what the radiation dose was at that point in the phantom. So you can't measure organ doses in a human. You can measure human doses in a phantom. The other thing you can do is you can do a computer simulation which calculates the radiation at certain points, calculates the entrance surface dose. This is what virtual radiography does. And you can have certain other simulations that can calculate the radiation dose in a given organ in a mathematical phantom. And they're called Monte Carlo calculations. And you'll find research papers that use Monte Carlo calculations. And what they're doing is they're never x-raying anybody. They're putting all of the data, they're putting everything into a computer calculation. The computer is coming up with a simulated x-ray, x-raying a simulated person, and that simulated person has simulated organs, and the doses in all the organs can be estimated using the computer. Okay, next place we get a measurement is the exit dose. So the exit dose is the amount of radiation leaving the patient. So that's not a measure of the radiation dose to the patient, because if the patient absorbs all radiation, then this would be low, but the patient would of course absorbed a lot. And the system dose is another measure really of exit dose, and that's the amount of radiation that gets to the receptor or the detector. And virtual radiography calculates system dose, but it also calculates something called exposure index, which is related to system dose. So as the system dose changes, so the exposure index changes. And different manufacturers have different exposure indexes, and so they change in a different way compared to system dose. And then beyond the receptor, you could actually measure the amount of radiation that gets through the receptor. And that I'm calling that lost dose here, which is the amount of radiation that gets through and is lost to the process. There is a little bit that gets through the receptor. And of course, there is some scatter that comes out of the patient that goes in different directions other than to the receptor, and that becomes occupational dose, or dose to a carer and comforter, and that can be measured there. That's what we get occupational doses from. Okay. So as I've said, these are all measures of energy. So they're in blue here on my slide. And normally the unit that we use is the grey, and it's called absorbed dose. Okay. But there are some other units out there, some old units and non-standard units. One is called the rad, and the rad is 0.01 gray, or 10 milligray. That's equivalent to a rad, and it's a measure of absorbed dose. It's energy still, and it's used in America and can be found in some papers. And the reason America's kept hold of it is because it's a very useful unit, because this is sort of, one rad is going to be likely about the amount that some X-rays count up to, whereas the grey is a really big unit and you end up having to use milligray or microgray. The rad is just about the same, the right size for diagnostic radiography. Another one you might come across is KERMA, and KERMA stands for kinetic energy released per unit mass, KERMA. So it's a measure of energy released per kilogram rather than energy absorbed per kilogram, which is a bit of a physics definition, because in diagnostic energy, in diagnostic radiography, the energy released and the energy absorbed is virtually identical. So KERMA is basically the same. Any measure of KERMA is the same as a measure of dose in diagnostic radiography. If you go to radiotherapy where we're using much higher energy beams or we're using protons, then that's different, and the KERMA and the dose would be very different. But we're not in the ballpark, we're using X-rays, and so KERMA and dose are very similar. So you do sometimes see KAP for KERMA area product instead of DAP for dose area product, but you can treat these as equivalent. Okay. Another one that's old, even older, is the Rontgen. So you might come across a unit called the Rontgen, or it might be just capital R, and it works out at 8.77 milligray, so that's how you can convert them. Now this is a unit of exposure, and this is not how we used the word exposure earlier. This is a different use of the word exposure. Exposure in the physics terms means a measure of electrical charge released when air is irradiated. So it's literally the amount of electricity generated by the X-ray beam inside some air. Yeah? Because air, you know that sort of lightning will charge up air, and electricity will be released because of it. And similarly, X-rays will charge up air. They create ions, and those ions then move, and then a bit of electricity flows. And the SI unit of exposure is coulombs per kilogram. So we shouldn't really be using them, and you can criticize a paper for using Rontgen or coulombs per kilogram as a measure of energy, because it's not a very good measure of energy. Exposure index. So we've said that that's relative to the dose to the plate, but there's a lot of different ones out there. The modern standard is roughly 100 times the absorbed dose in microgray. So that's the exposure index that virtual radiography uses. So you can work out the dose in microgray by dividing the exposure index by 100. in the case of virtual radiography. But again, it's a good measure of the dose to the plate, but it's not a good measure of the dose to the patient. If it's good, it's good for relative radiation doses. So if you were to see a dose that's twice the exposure index, that's twice as big as you expect, then it's likely the patient has had twice as much radiation as they should have. So you can use it as a relative measure, but not good in a scientific sense. Talking of that, the X-ray exposure dose that a plate can have, in this case, this is an example data sheet for a Pixium detector made of cesium iodide, so this is a DR detector. 0.2 to 3 microgray is the sort of system dose that we would expect on the plate. So that's millionths of a gray. So a very low amount of radiation can be detected. And the maximum the plate can cope with is 85 microgray. So if you go below 0.2, then the image quality is going to be so low that the manufacturer doesn't recommend it for any sort of diagnosis. Over 3 is going to be an overexposure. You didn't need to give more than 3, but the image quality probably would continue to improve beyond 3 until you get to something like near the maximal dose. Once you get to the maximal dose, what you're getting is burn-in, and that burn-in is going to really reduce the image quality, and you're not going to be able to see any contrast. Okay. And these are the exposure indexes. As I've said, virtual radiography uses this IEC dose exposure index, and we say that we aim for an exposure index of 250 or 300 to get into the range that is normally acceptable, around 2.5 to 3 microgray, up to 5 microgray really for most detectors, including CR. DR tends to be about half of CR in terms of its requirement. But as you can see, if you use software from earlier versions of the manufacturers where they hadn't yet taken up this IEC standard, then they can have all sorts of weird numbers which sometimes go smaller when the dose gets higher, and sometimes they're logarithmic, so a small change is actually a big change in dose. Okay, so let's just have a recap. So absorbed dose can be measured, and this is in blue here. It's measured in grey as energy, and the two measures that are common is entrance surface dose and dose area product. And if you're using a phantom, then you can actually also measure the mean absorbed dose in an organ or tissue by putting the TLD inside the actual phantom. You then have to convert it to equivalent dose, which is a non-issue in diagnostic radiography because the conversion is 1-to-1. Absorbed dose to equivalent dose is 1-to-1 conversion. We'll talk about that in a minute. And then you have to convert it into effective dose. An effective dose in pink here is measured in millisieverts, and the way that we do that is by using what's called the tissue weighting factor. And you need to know, as I said earlier, you need to know a lot about the exposure. You need to know who was exposed, where they were exposed, what age they were, what gender they were, you know, which projection was used, and all those things to be able to make this calculation. And you can also convert effective dose. We can actually convert that into a risk of developing cancer or death, the odds, if you like, of getting cancer. Collective dose is also sometimes referred to, but it's as a concept, it doesn't really have any meaning. It doesn't really matter that hundreds of people have a chest X-ray. It only matters to that one person. You know, it matters in a term of planning healthcare. You know, if you think that you're going to generate a lot of cancer, then you need to have better cancer services and you need to fund cancer. So it works on a planning basis, but it doesn't work for an individual. Okay, and there's only one more old unit to cope with that you sometimes see, and this is the American version of the sievert, and it's called the REM, the Rontgen equivalent man. And it's equal to 0.01 sievert, 10 millisieverts. So 1 rem is 10 millisieverts. It's equivalent like that. Okay, so how do we get to risk from energy? So we've measured the energy. So most of the doses that you see written about are just reported in the literature as milligray. However, some radiations are more biologically damaging per unit energy than others. They have a higher radiation weighting factor, and this is known in the literature as WR. We need to calculate the equivalent dose to take into account the WR. Now, this is useful when you're dealing with radiation in the world, but it's not useful in radiography, because in radiography, all the ionizing radiations we use, which is X-rays, the gamma rays that come from technetium-99m and other radionuclides that we inject in people in nuclear medicine, and beta particles and positrons that we use in positron emission tomography, they all have the same biological effectiveness, which is 1. So absorbed dose is equivalent, is exactly the same as the equivalent dose in diagnostic radiography. So it's a 1-to-1 conversion. So here's our radiations: electrons, gamma rays, and muons less than 1 mega electron volt is 1, and it was 1 in 1990, and it is 1 in 2007. So these are when you use high energy beams of neutrons, then you can use these calculations and get larger numbers. And if you use very high energy protons, then you get to 2s. And if you use things like, if you have heavy nuclei or alpha particles, then it's 20 times. The equivalent dose is 20 times the normal dose. So someone, for example, who has been poisoned. So there was a guy called Alexander Litvinenko, who was a famous Russian, who was poisoned by somebody spraying alpha particles, polonium, which gives out alpha particles, sprayed polonium on his sushi, and he ate the sushi and it ingested it. It was inside his body. So the dose numbers that may not have been that great. It might have been like he might have got 100 milligray or 200 milligray, which if you were having a CT scan wouldn't be so bad. But because the alpha particles are 20 times as damaging, then it becomes 20 times 100. So it becomes 2 grays worth of dose equivalent, which then kills him. Okay. So the other thing that risk depends on is what part of the body is irradiated, as we've mentioned already. So some tissues are much more sensitive to energy absorbed than others. They have a higher tissue weighting factor, which is called WT in the literature. We need to calculate the effective dose to take into account the WT for all irradiated tissues. So this is the most difficult step and the one prone to the most error. There can be some gross assumptions underlying what seems to be a scientific study. Also, these values have changed over the years. So if you're reading a study prior to 2007, then the risk estimates will be wrong compared to what we understand now to be the tissue weighting factors. Usually the tissue weighting factors have gone up in most tissues, so it's actually usually more risky than it was if it was calculated before 2007. But there are some exceptions. Now, some of these papers sidestep this issue and don't bother calculating effective dose at all, which is fine. But if a paper does try to calculate effective dose, then you can critique its use and its assumptions, because quite often they use standard man, who's like 70 kilos, and that they can use standard man as where the organs are and how big the organs are and how much soft tissues around the organs, even when you're x-raying an obese population. And obviously that won't be a very good estimate. Or they can use standard man and then include females in the population and then generalize their findings to females, where of course females' organs are somewhat different. in certain different sort of places, etc., including especially the breast tissue, of course. Okay, so this is the tissue weighting factors, and you can see that ICRP 103 in 2007 has some tissue weighting factors. These are the ones we're using nowadays. ICRP 60 was published in the 90s, and they're the ones we used up till recently. ICRP 26 was published in the 70s, I think. So you can see that gonads used to be seen as quite radiosensitive, and then they were dropping to 0.2 in the 90s and dropped right down to 0.8. So they're the big losers in terms of radiosensitivity in the tables. The big increase in the tables is the breast. So the breast was seen as radiosensitive, and then it dropped down to 0, roughly, very low, and it's gone back up again in the new tables. So they've redone the data. And so now, you know, we should really take more care of the breast than we do the gonads. And this is what's behind all this drive not to bother using gonad protection anymore. But, you know, start taking more concern about breast tissue irradiation. And one of the ways we can stop breast tissue being irradiated is by doing posterior anterior projections instead of antero-posterior projections. And this highlights the difference between absorbed dose and effective dose. So for example, the entrance surface dose of a chest x-ray, if we do it PA, by putting a TLD on the surface of the skin at the back at the level of T7 and measuring it, may come out at something like 1 millisievert, 1 milligray. Yep. But if we then take the patient and turn them round and actually put that TLD on their breast tissue and x-ray it, it may still come out as 1 milligray of absorbed dose. But those two values, because the patient was antero-posterior in one projection, in one exposure, where the breast got a lot of the radiation, which is a radiosensitive tissue, and it was posterior anterior in the other irradiation, where the breast didn't get much radiation because it had been absorbed by the time it got to the breast, you can see that the effective dose is going to be dramatically different between an AP chest x-ray and a PA chest x-ray. And this is, you'll find papers which look at how the position of the patient, the projection changes things. So there are papers in the literature where they look at doing a right lateral versus a left lateral. And what it does is it looks at the organ doses and the radiosensitive organs. So the colon is quite radiosensitive, yeah, and the liver is less radiosensitive. So if you x-ray through the liver before you get to the colon, then you'll be protecting the colon, which is more radiosensitive. And so a left lateral should be less radiosensitive, less radiation dose than a right lateral. You see how that might work. Okay, the estimate reported may be different depending on the research method. So we've talked a little bit about this. So this is where you critique the dose in the literature. So critiquing the paper about how they've dealt with dose. So simulation, this is where you use the Monte Carlo computer simulation that I talked about earlier. A phantom, where you load the phantom up with TLDs so you can measure organ dose directly. And the patient, which obviously you can't put something inside the patient. So you have to either use a DAP reading, where you don't actually put anything on the patient at all, or you use an entrance surface dose measure, which is using a thermoluminescent dose meter and sticking it on the patient. Now that's going to be costly doing it that way, and of course you're going to change your radiographic practice doing it that way. So doing a DAP reading is probably the easiest way, and you'll find a lot of the papers use DAP readings as their measure of dose. But you can critique the paper. Entrance surface dose is probably a bit better than DAP, because remember that you know that as well as I do that some radiographers will open the collimation and include quite a bit of air either side of the patient, and so that isn't truly radiation that's gone into the patient, is it? Some of that isn't. So the DAP can be a bit variable depending on the collimation practices of the radiographers doing it. So, yeah. Now, the paper may just use grey, but then when it talks about its conclusions, it might start talking about risk. And that is problematic because they've never estimated the risk. They're just implying risk, because if energy goes up, absorbed dose goes up, then probably risk goes up. Yeah? But one of the important critiques of papers is to consider how they are implying risk. You know, how good are they at implying risk, and do they over-egg it, or do they put in a caution that they haven't actually done the calculation for effective dose, so there may be other things going on which may not eke out the answer, if you see what I mean. Okay, the other thing that you've got to critique the paper for is that there must be detail so that it can be reproduced and so you can understand what they mean by the doses. So the technique and exposure factors used must be included, because this helps validate the measures and generalize the findings. You know, you'll often find that they've used a really high MAS to get their dose values if they're using a phantom, which you think, well, hang on, would we really be using those values? And that might generate a lot of scatter, which might do other things and affect the machinery some way. The method of converting from dose to effective dose, as I've said, any paper before 2007 will have used old tissue weighting factors. So that's something you can comment on. And never accept just a percentage change in dose. So a 50% reduction of dose doesn't necessarily mean that you get a 50% reduction of risk. Because if the risk was already trivial, then 50% of nothing is still nothing. So saying, wow, look, we reduced the dose to this finger by 50% doesn't imply that the risk is reduced by 50%, because the risk was already nothing. So you've had no effect whatsoever, no impact. In fact, if we look at this, these are the typical effective doses for adult patients based on DAP and ESD measurements from 2005. So here, for example, you can see that a foot oblique, there's a very, very low value. So the absorbed dose is very, very low, and therefore the risk is going to be very, very low. So for a paper, another thing you can critique a paper about is if it's really writing a paper about how to reduce the radiation dose of a foot X-ray, you've got to ask the question, so what? You've got to ask the question, why? Why are we trying to reduce the dose to a foot X-ray? Because the dose is already so low that we should be getting on and actually trying to reduce the dose on some of these more, important examinations. CT heads, for example, where we had 0.00001 millisieverts, here we're getting up to 10 millisieverts. Yep, which is a whole rem if we go to the old units there. 10 millisieverts for a CT chest, abdomen, pelvis. So this is definitely something ripe for optimization. It certainly passes the so what test if someone's writing some research on how to reduce the dose in CT. Okay, so we've got it into sieverts, but let's try and move it to something a bit more understandable, because the sievert is a pretty complicated concept and not many people understand what a sievert is. The risk of developing a fatal cancer is basically considered to be 5 times 10 to the minus 2 per sievert. So that means 5% per sievert, which means 1 in 20. So your risk of contracting fatal cancer from 1 sievert of radiation is about 1 in 20. Now, nobody gets 1 sievert of radiation because that's a huge amount. But if you then look at your 10 millisieverts, so that's 1/100th of this. Yeah, so a CT scan of chest, abdomen, pelvis gives you 10 millisieverts, and 10 millisieverts is 1/100th of a sievert. So that means you have to multiply the 20 here by 100, so it's 1 in 2,000. So the chances of getting a fatal cancer from that CT chest, abdomen, pelvis is 1 in 2,000, which is not really isn't non-trivial, is it? So that's for a working the whole population. So this is the paper that tells us about the 5% per sievert estimate. If you're looking at workers rather than just the whole population, then that cuts children out of the equation. So because the 1 in 2,000 estimate included children as an average, if you take the children out, then it becomes 1 in 2,500. So it becomes less risky, because children are much more likely to get cancer if they're exposed to radiation. Genders as well. So this is an amalgam of female and male people. But the risk from breast cancer for men is almost 0. So for women, it's sort of about twice as much as the value given in tables for all genders. So here's a few differences here. So we're looking at different ages and different genders. So you can see that exposing a 20-year-old to a certain amount of radiation is going to give a higher radiation risk, cancer risk, than exposing a 60-year-old to the same amount of radiation. And similarly, a female patient has got a slightly higher risk than a male patient of all cancers. Here's some more specific details. So these are lifetime cancer risks based on certain X-ray examinations. So you can see that a cervical spine is more risky for females than males, but after the age of about 60, then there's virtually no risk. Check the graphs changing their axes here. So a thoracic spine is way more risky at the age of 80 than a cervical spine is even at the age of 20. Yeah. A chest X-ray, even in a child, is way less risky than even a thoracic spine at 100 because of the dose reached here. But this is, have a look at this at your leisure. This is why it's very, very difficult to draw conclusions across or from one dose estimate. Yeah. So when a paper really ought to be very clear about who it's X-raying and who these results are applicable to, and whether they're applicable to all age ranges and all genders. That's something you can critique them about. Obviously here we've got much higher numbers here. Bariums are giving us into the 300s here, of 300 per million. So these times 10 to the 6. So it's lifetime cancer risk. We're up to 300 in a million. And then we get our CT scans. So our CT chest and abdomen is 1,600 per million, which gives us this 1 in 2,500, something like that. But even then, if you're 80 or 90 or 100, the chance is very low because you haven't got very long to create a cancer diagnosis. So what's it all mean then? And how does risk compare to other risks that we take in life? This is the problem, isn't it? We're not very good at balancing risks. So here's some risks that have been sort of calculated. So for example, in your work, if you work in construction, then you're taking an extra risk of 1 in 16,000 of death. just from being a brickie and working on building sites, which are quite dangerous. So smoking cigarettes, 10 cigarettes a day, 1 in 200 risk of developing an extra death. Wow, excess death. So, it's put it into perspective. A smoker shouldn't really be concerned about an X-ray. And in fact, they've come up with a scheme of lifetime cancer risk here, where basically anything less than 1 in a million is what we consider to be negligible risk. So foot, knee, chest, cervical spine, these are less than 1 in a million, so they are safe, basically. They have negligible risk. Still shouldn't be doing them unnecessarily, but shouldn't be that worried about them. Then you get minimal risk stuff. So cervical spine in females is a minimal risk, whereas in males it's a negligible risk. And this is because of the increased sensitivity of the thyroid in females. So we want to avoid thyroid cancer in females. So if you're looking at doing a paper and comparing cervical spine, you should be thinking about female patients. So your protocol might be more strict with a female patient than it is with a male patient, because you might be doing female patients PA and male patients AP for a cervical spine, for example, to protect the thyroid in female patients. You see how that might work? Okay, well, thanks very much for listening. That was an hour of discussion of risk and dose in the literature.